Hello, everyone. My name is Jonathan Fritz. I'm the Chief Innovation Officer for Chime. It's my pleasure to welcome everyone to today's Chime Innovation Beyond the Edge. This 12-part series is designed to share creative problem solving in response to COVID-19 and highlight innovations implemented by your peers. Today's session is Inspired Innovation, how COVID-19 has catalyzed new way of thinking in the healthcare industry. We know you're incredibly busy at this time, so we appreciate you joining us today. Why is Chime presenting this series? Well, we believe that change presents challenges and problems, but also opportunity. Opportunity for creative problem solving. Chime members have faced many challenges, from setting a remote workforce, spinning up and training clinicians on telehealth, infrastructure and resource constraints, and soon, how to plan for the next phase of this war, transitioning to a new normal. From what I've seen, our members are some of the most creative problem solvers, truly leading innovators. Innovation isn't all about bright, shiny objects. Innovation during times like this, positively impacting and saving lives, are really the most impactful and valuable innovations, period. Before we get started with the presentation, I'd like to cover a few details. Our session will have two main parts. We'll have a presentation from our speaker, and then we'll have virtual breakout sessions that will include 4 to 5 people, so everyone can have a candid discussion on the topic presented. First, we're going to hear a presentation by Dr. Stephanie Lahr, CIO and CMIO at Monument Health. At the end of the time, we'll bring everyone back together to wrap up and review any outstanding questions and follow-ups. If you're unfamiliar with breakout rooms, that's okay. I'll give a few brief instructions prior to splitting participants into the breakout rooms. We'll have everyone muted during the session. If you'd like to ask a question, please use the chat function to alert the team. The chat window will appear on your right side panel. To ask a question, type your message inside the panel, press the send key. Speakers will try to answer as many questions as possible at the end of the presentation. However, there's a chance we won't get to everyone. If that happens, we'll collect all unanswered questions and send responses via email to the attendee list. Also, we are recording this presentation. This will be saved and stored on the Chime site, so you can go back and review any details once we finish. One important detail, discussions within the breakout rooms will not be recorded. If you have difficulty listening to the live audio stream through computer speakers, keep in mind that you can connect to audio via phone. If you need help with that or any other technical detail, please use the chat window to send us your questions. For those connecting via phone and your computer, please message the host with your name and phone number. Our host will then merge your phone and computer connections. Lastly, by attending today's session, you will earn 1 continuing education unit for CHCIO, CFCHE, and CHISL certifications. We will review the attendee list following this session and distribute CEUs accordingly. With that said, I'd like to introduce our speaker for today. Dr. Stephanie Lahr, CIO and CMIO at Monument Health, is a great friend of Chime, and I consider her a close friend as well. Stephanie is a board certified internal medicine and in clinical informatics, as well as a certified healthcare CIO from Chime. It's my pleasure to welcome Dr. Lahr.
Thanks, Jonathan. Happy to be here. So I wanted to spend some time today talking about things that we are working on at Monument Health, some of which may be similar to things that all of you are working on. But I just am so appreciative of the opportunity to be able to collaborate and share the ideas that we're working on and hear from others in this time. The ability to learn from each other and rapidly iterate is really, really important. So I look forward to both my presentation to you, but also I'll be joining one of the breakout sessions for the discussion afterwards. I also wanted to note there are a couple of slides in here that I'll just touch on briefly that are questions. I won't spend any time on those. They're really meant to just provoke thought for the subsequent discussion in the breakout sessions. So with that, we'll get started. Just to tell you a little bit about where we're at and who I am. As Jonathan mentioned, I have the dual role of CIO and CMIO for a healthcare system in Western South Dakota, Monument Health. We are the largest healthcare system in Western South Dakota. We are in general a relatively rural and remote location. I wanted to spend just a minute actually talking about where we are in South Dakota specifically, because we know that in the last few days, South Dakota has been in the news with respect to the COVID-19 outbreak. And I think that as I talk through kind of the elements that we've been working on here at Monument Health, all of the things that we can focus on in our own health systems are very dependent on where we are locally in our own trajectory. So some of the things that I'm working on might be different than somebody in a location that is further along in their trajectory, their number of cases, etc. So just for clarification purposes, while there is now a significant hotspot in the state of South Dakota, that location is approximately 320 miles away from where we are, with a lot of space, as you can see on this map, which is basically unoccupied between here and there. So while we stay in close communication with our healthcare partners on the eastern side of the state, as well as our government officials, so that we can all share and collaborate together, a lot of what's happening over there is somewhat different than what we are dealing with. Our numbers are still quite low. 10 positive cases is what's currently for our county on the South Dakota website for the Department of Health. So I just want to spend a moment sharing that because again, I think it influences where our thought process is and our emphasis is in the work that we're doing. So as we move into kind of what are the things we're doing, there's another talk that I've given actually with CHIME where we talked about innovation, and this is sort of my definition for innovation. And this goes to Jonathan's comment about it not necessarily being about bright, shiny new objects or an innovation center, which is a building or a person with a title, but really innovation, in my mind, is the use of creativity and ingenuity to solve the problems that lie before us right now. No time in my career have we had more of an opportunity to innovate to solve the problems that are before us in such a unique and really important way. So with that said, what are the things that sort of maybe stand in the way normally of what we do, and why aren't we innovating and creating all the time? So this word cloud, you can see healthcare in the middle. We see things like finance, Medicare, coverage, government, cost, service. Some of those words that are some of the biggest words in this word cloud often create challenges for us in being able to innovate. It also means that not no one's particular fault. We tend to have areas where we're rowing, even within one organization, we're rowing in different directions, trying to solve problems in each of these areas, and maybe not in a unified way. Right now, we have an opportunity to have a situation where we are all rowing in the same direction. So what does that mean? That means that within our organizations, we've removed a lot of the other focuses, which again are worthy of time and attention, but right now we all have one worthy cause, one clear goal, which is how do we safely and effectively get our communities through a pandemic crisis in a way that meets our local communities' needs, both from a healthcare perspective, also from a financial perspective, from a social perspective, from a public health perspective. And so with that clear goal and extremely worthy cause, coupled with the urgency in achieving those things, and then added to by the removal of certain regulatory and payment constraints that we've had in the past, we really have a wonderful opportunity to think outside the box and really tackle almost anything we want to in any way we want to. So from the very beginning, and for us, the beginning, I would say, was around March 16th was when we really started executing on the kinds of endeavors I'm about to share with you, which is really just 1 month ago. And the world has changed, drastically in that time period. But within that time period, we've been able to sort of hone in and focus on what is really important in our community based on the numbers we're seeing and what we think is going to be coming, our resources, our population, etc. So I want to talk about what that path has looked like for us. As I do that, I will put the first question out there for thought, which is, are you breaking the rules that you and your teams have created for yourselves? And I mean, when I say teams, I mean your entire healthcare organization, not just your technology teams, not just your clinical teams, not just your infrastructure or other teams, but literally all of the teams. Has your entire organization sort of set some of the rules and the structure aside to figure out new ways forward? So if we're going to break down the barriers and innovate and look for new ways forward, we still have to have a structure. Because again, while we're trying to get everyone or maintain everyone rowing in the same direction, they need some guidance. They need some imagery to understand what does that mean? What are we trying to do? There are still a number of elements to tackle in this. So this is the schema that I created. This is for my team, my technology team, the 206 folks that work for me, both in informatics and the rest of the technology division. So I wanted it to be simple, I wanted it to resonate, and I wanted it to help people figure out the path. We shared this across the organization as well, so that our operational leaders knew what it was we were working on and the prioritization of that, and were able to provide feedback if it didn't fit. That didn't turn out to be the case, and this was what was accepted by the organization. So first, keep sick patients out. Meaning, what do we do for the patient population that we think will be coming in with symptoms consistent with COVID-19, who we know could be infectious to other people, and what do we do to help them get the care that they need, the advice that they need, but do that as safely for them and their families, as well as protecting the rest of our community and our healthcare providers. So that was our first focus. How do we keep, to an extent, the sick patients out of our settings and keep them home whenever possible, but still give them the care that they need? The next step was, how do we keep the well patients home? Now, well is certainly a relative term. What I mean by well in this setting is we have patients with chronic illnesses, multiple things that we monitor over time. We have healthy patients that might have something come up that isn't COVID-19 related. So what do we offer those people who might be some of our high-risk people that we would not want to come into contact for exposure, or just in general continue to need our care, but we may not want them coming into our spaces, or they may not be comfortable coming into our space. So how do we keep them at home, but also receiving the care that they need? The third priority then, and again, this from a perspective of we have not seen a large influx of inpatients yet, our third tier was to protect our staff and providers with a pretty significant focus on the inpatient side, where we know the likelihood of caregivers and physicians coming in contact with a patient that is sick and potentially becoming sick themselves is our highest risk for healthcare workers. And then the fourth priority being, how do we help our patients remain connected with their families, connected to life in general, given that the reality is most of our healthcare organizations have drastically limited our ability for patients to have physical visitors coming in to see them. And so we needed to come up with some opportunities for them to try and keep that human connection, even if it couldn't be in person. So we have a couple of phases. We've worked through some testing algorithms, creating a triage center. We expanded telehealth, and then have worked on some acute care telehealth options. I'm going to talk about those in a little more detail. So these are the things that we've already done. And the things I want to highlight in here are really kind of where these ideas came from, because and how we got to them, because these are some of the very similar things that I know many of you are doing. So we built an online symptom assessment chatbot. This was built in just a couple of days. It came from one of my application managers. He was very excited about the ability to be able to contribute positively in this area. And so 2 days from decision to execution, we had this live on our website. We also identified as an organization that we needed to have a phone line for patients to be able to call into. We were not a telehealth heavy community thus far, so we knew going direct to things like video visits could be challenging, and we also wanted to intervene with patients as early as possible in whatever the symptomatology was they were going through. So we needed a nurse triage line, but we didn't have one. And I didn't have a bunch of nurses to be able, from across the operational side of our organization, to start that and make it available literally 16 hours a day. So I have nurse leaders and informaticists that work for me in IT. And over the course of a couple of days, we put together a plan. And since March 16th, have been running a nurse triage line 7 days a week, 16 hours a day, mostly staffed by IT nurses, and now supplemented by some of our other nursing staff whose areas are maybe not open right now or have lower volumes. Telephone and video visits. We had really no telehealth deployment from an ambulatory perspective, and certainly not in a direct-to-consumer fashion, mostly because of regulatory and payment-related constraints that made those not very relevant in our population until the recent changes. So we went from nothing to fully stood up basically within 3 days with the help of a vendor that I'll talk about a little bit, and some of the vendor partnerships that can come out of a situation like this, as well as the enthusiasm of both my team and the operational team to make this happen. And so within a course of about 7 days, we went from nothing to every specialty and every practice across our health system being live. We then moved to start talking about how do we leverage technology in our inpatient environments, knowing that we may have a limited number of providers to be able to provide the care. How can we centrally monitor our most complex patients who are in our ICU but may also be scattered through other areas of our hospital when we are overrun in our primary ICU location. So we've been working on technology for that, as well as additional options for hospital rounding. So on this slide, really what I want to focus on is the part in yellow. So as you can see, we used Epic for documentation. That's our EHR. We quickly were able to come to an understanding and agreement with Dr. First, which is a company we already were working with in another space, to use Backline for their video capabilities. And again, within 3 days, went from concept to live. We do telephone and video visits across all our specialties, and now we've worked into a variety of sort of more non-traditional areas like our anti-coag clinic, lactation, diabetic educators, hospice, etc. But the thing I think is striking about the work that we did here is it really broke a lot of the rules that we've historically set, even for ourselves in informatics. I never before would have said, we're going to come up with the idea and go live with it 3 days later across an entire system. But time was of the essence, and interestingly, we made it a success. We didn't use our typical project management resources. We didn't use our typical resource planning resources. We didn't use our typical decision-making resources. We basically took a small group of people and said, this is what we need to do. We're going to execute on it. We're going to make the best of it. We don't need to be perfect. We just need to be, making this work. We also took a self-deployment with a centralized support model. We basically let the organization know, in order to take everyone live over the course of a week, we would not be at their elbow as we normally would be to roll out new technology. So we used a combination of live WebExes, some recorded WebExes, and other virtual tools to essentially put the tools in the hands of our operational teams and let them run with it. And what they showed was that they were absolutely capable of it and that it was quite successful. The other piece that came out of this was some of the thought that we're starting to have around care delivery model, and this was in the ambulatory space, and we'll talk about this a little bit more on the inpatient space, but really what does it look like to care for patients differently? And one of the things that we came up with was what I've called a physician conservation model. So what that really means is that we have a group of physicians in oncology who we have a small number of physicians and a very vulnerable population. We now have only one oncologist and one radiation oncologist on site at a time, while the other complement of those specialties are actually working from home. That way, if we were to have an outbreak in our cancer center with a patient or a caregiver that became sick and others that became exposed and needed to bring those out of the environment, we know we have a workforce that can come in and do the work the next week, because chemo and radiation is not something that can be delivered without people being in person. So just a brief look at our numbers. You can see back around the time that we launched telemedicine, we really were doing 0 visits in this space. And now we're doing over 600 visits a day in a combination of telephone visits as well as video visits. And this just really speaks to the rapid adoption and really operations really amazing willingness to jump into this and execute and make it a new part of their normal work. On the inpatient side, this was an idea that came from my IT infrastructure architect. I shared with him kind of the problem I was trying to solve, looking for an ability to monitor multiple patients at one time from a central studio who might be diversely distributed across the organization or across the hospital. And he said, hey, we use a system, you know, for telesitter. Maybe we could use that. So we embarked down a road that we're rolling out right now, where our ICU providers, both physician and nurses, are able to be in a central studio and monitor patients that are diversely distributed across the hospital and have video and audio interaction with them, allowing them to be able to round and talk with those patients, even potentially looking at monitors and zooming in on various things, avoiding the use of PPE to go into those rooms repeatedly, as well as avoiding the potential repeated exposure. So again, thinking about different ways that we can do things using similar technology or new technology. For rounding, we're looking at other options like using security cameras that have video and audio capabilities with an app on a device that within our network, we would again be able to have one-to-one interactions with patients in a room using video and audio. We are looking at things like the use of Zoom and Microsoft Teams, as I'm sure many of you are as well, in what are the opportunities we have for rounding, and how do they accomplish the goals of limiting PPE use and limiting exposure. To sidestep a little bit from the work that we're doing clinically, we have over 400 caregivers working from home at this point. And really, I think this is pretty remarkable. Our total organization is about 4,000 people. To have 10% of our caregivers home is impressive, because really healthcare has been quite resistant generally to having caregivers at home, and this has been very successful. My team has been working from home, actually about 90% of them, 3/5 of the time for quite a while. So this was an opportunity for us to teach and share with the organization best practices around this, and we've added some new things. So we do a Facebook Live, we do weekly games. In fact, as of right now, I have team members submitting for our virtual game show, and we do daily leadership huddles where we bring everyone together. So we do weekly movie nights where we all watch the same movie at the same time, because what we're finding is while people are separate and working from home, we have to be able to maintain the sense of team. What's not on this slide, but similar on the medical staff side, we created a Facebook site for our physicians. So we approve them. It's a private site, but we can put information on there. They can ask questions. We can share that information back and forth. That's been extremely successful. And we do a weekly virtual grand rounds, again, to try and help keep the flow of information to everyone going, and with a specific set of use cases so that we have the right information for the right people. Couple of things I just want to mention very briefly. our collaborations are going outside of even our organization. So we are working with local businesses on things like hand sanitizer production of testing swabs, so things that we're all running out of. We also created an in-house, and what you can see in the picture here is an in-house N95 sterilization process using UV. We had these UV towers in our GI lab and didn't really realize it until people started talking about it. And we're now 2,500 masks a day sterilizing and being able to re-deliver to people that we take the same mask and you have to deliver it back to the same person. But when you consider the shortages we have, that's well worth the effort to be able to reuse these. Again, things that as a healthcare system, we never planned to be in a reuse or a manufacturing sort of role, but that's what the situation called for, and so we're bringing people together to do that. So a question that I would have for you is, what are the sourcing ideas that you're using, and what have been the most successful? Where are you getting your ideas, and what are you continuing to go back to hear about new ideas or come up with new ideas so that you can be innovating in these ways as well? Just to share a few things that we have in the pipeline, not live yet, but that we're working on: efforts related to patient and family communication. My team is working with our radiologists on some COVID-19 X-ray, artificial intelligence, and neural network. We're working on completely changing our onboarding and training strategies for EHR, and really many of the elements of the things that people need to be onboarded to so that it can be quicker as well as virtual. We're looking at home monitoring options so we can expand the use of what we're able to do in the home. We're looking at other uses for chatbots and working on internal communication tools for both uses in Surge, but just to improve communication in general as we move through this and plan for, as we've talked about at the very beginning and that Jonathan mentioned, is when this is all sort of said and done, whatever that means, what is the new normal? What are the pieces that we can really learn from in all of this and take forward? Because the reality is we aren't going to be able to use an old map to explore a new world. So right now, what we're all doing is writing a new map so that we can go and explore in this new world. And it's really, honestly, an exciting time in the midst of a scary and difficult time as well. So with that, I thank you for your time and look forward to the breakout sessions.